Good afternoon. My name is William Moulton from Wiltshire Council, and I'm providing the backroom support for this webinar. I'm really pleased to be supporting my NHS colleagues to use this new technology to expand understanding in this important field. I'm going to give you a quick introduction to how this works, and then we'll get going. Before I get started, on the bottom right-hand side of the screen, you should be able to see a little box with the letters CC in it. If you want to see closed captions of the speaker's words, then click on the CC button and they should appear about half a minute in. The system sometimes takes a little while to get warmed up. This is the first time this group has used Microsoft Live Events, and we're all getting used to the tech. So if there are any technical problems, please bear with us, i.e. there might be a slight delay between transitioning from one person to another. We would really welcome any feedback that you have for us about how we might make better use of this technology in the future. And you can submit your views by visiting www.menti.com and using the code 164911. And you can see that at the bottom of this slide. If you're having any technical problems, I suggest closing Teams or your browser, reopening, and then clicking on the meeting link again that we sent earlier. If you're hearing an echo of the speakers, it may be that you've got this meeting open twice, maybe in multiple browsers. You might need to close down all but one of those windows, and that should fix the problem. You should be able to see the Q&A panel. For some of you, that might be beneath your screen and you need to scroll down and see it. You may need to click on an icon of two overlapping speech bubbles to open this panel. So this is where you can submit questions. And if you include your name, we'll assume that you're happy for this to be announced on air as your question is asked. So in a few moments, I'm going to hand over to Ingrid, who's going to introduce Thessa, who is giving the presentation. So during the presentation, there'll be opportunities for you to submit your written questions via that Q&A panel. And then our team of moderators will then feed the top questions to Ingrid, who will put them to Thessa at the end. It would be great that when you're submitting your questions that you say who you are and where you're from. Okay, without further ado, I'm going to stop this slide and I'm going to share the meeting with Ingrid and Thessa.
Over to me. Hello, I think I've just been given the green light to go ahead. My name is Ingrid Wilkinson. I'm the lead physiotherapist in the community team for people with learning disabilities in Wiltshire in the UK. We're really pleased to be joined by Dr. Thessa Hilgenkamp today, who's based in the States but originally from Holland. Hi Thessa. Hi. I'm just going to introduce a little bit about the reasons behind inviting you to talk today before I hand over completely to Thessa. So in our physiotherapy team within the wider health team in Wiltshire, we wanted to become a little bit more proactive in the way that we helped the people with learning disabilities. In particular, we wanted to become a little bit less reactive, just coming back from just responding to referrals that we received. And the idea behind this was to help everyone to lead slightly healthier lives and avoid preventable ill health issues. Since 2017, we've been running a Stay Active, Stay Well campaign in the county, where we've been partnering with service users, their families, support staff, paid as well as voluntary organisations, the Wiltshire Council and Wiltshire Health and Care teams across the health sector to try and come together to avoid this preventable ill health and encourage physical activity. So we've had activity days, we've had 3 of them now over the last couple of years, and bringing together all of these people, encouraging lots of different ways to be active within people's homes, in the community and outside. And we've tried to continue this a little bit during the pandemic by having some stay-at-home activity advice as well. So I'm really delighted today to introduce Dr. Hilgenkamp to talk about this important subject. Thank you, Thessa. Over to you.
Thank you, Ingrid. I'm going to be sharing my slides right now. The information that we have on physical activity and fitness for individuals with a learning disability, I think, is a really important topic, and I'm very happy to be sharing that information with you guys today. First, I have some disclosures. I have no commercial interest, but I do want to acknowledge the two funding agencies that have supported the research that I'll be presenting in this presentation. And the acknowledgements are for the Kennedy Shriver National Institute of Child Health and Human Development and the People Program Marie Curie Actions of the European Union. Further, I'd like to thank everybody for joining. I'd like to thank Ingrid Wilkinson of the Wiltshire Health and Care for organizing this webinar and inviting me to share, especially in times like this where we don't get to interact that much with each other. It is a great pleasure to share the passion that we all have for physical activity for individuals with learning disabilities. Before we get started, I just want to introduce myself a little bit so we kind of know what we're kind of talking to. I can't see any of you, so it'll be a one-directional introduction. But I started off with the training in human movement sciences in the Netherlands. I did my PhD in Rotterdam in the Netherlands on physical activity and fitness in older adults with intellectual disabilities. And after that, in different parts, I did a 3-year postdoc at the University of Illinois at Chicago, after which I transferred to the University of Nevada in Las Vegas, where I am right now. That was last summer, so I've been here for a year, and I started my own cardiovascular research and exercise lab. All in all, I've been involved in about 12 years of research with individuals with intellectual disabilities and with Down syndrome, all on physical activity and fitness, so that's my main topic. I work both at universities and for support provider agencies, so I hope to be able to make that translation between those two perspectives. And for my own activities, I love to run and to dance. Dancing is currently out of the question for all the reasons that we all know. But running and hiking is even in the temperatures here in Vegas still a good option. Having worked in different countries and being part of the research community, there's some differences in both the actual context in which we support people with intellectual disabilities or learning disabilities. And without going too much into those differences, because that would take another hour to describe the differences between the US, the UK, the Netherlands, it is important, I think, to get some common ground on the terms that I will be using. So in the US, and what we're most comfortable in the Netherlands as well, we use intellectual disability as the sort of definition or the term to describe the population. The definition covers intellectual functioning and adaptive behavior, and it originates before the age of 18. This is very, very similar to the definition in the UK for learning disability by the Department of Health, because it also includes impaired intelligence and impaired social functioning, and also starts before adulthood. So in this presentation, I've tried to stay true to the reference and the research that I'm using, where to use intellectual disability where that was the original term, and I've tried to use learning disability as much as possible in every other place, but just to make sure we're talking about the same group. So those words can, in this presentation, be used interchangeably. Then for the people who are not familiar with Down syndrome specifically, that is a genetic disorder. It is the most common genetic cause of intellectual disability, with about 15% of all individuals with an intellectual disability having Down syndrome. It causes intellectual impairment and some physical abnormalities. And because of those physical characteristics, I will be talking about Down syndrome specifically in parts of this presentation. So hoping to have clarified those words, this is kind of the objectives. These are the objectives for this presentation. We got a lot of ground to cover. So first, I'm going to review quickly some of the benefits of exercise and physical activity, specifically for individuals with learning disabilities and Down syndrome. Then I'm going to go over some specific exercise physiology, of individuals with Down syndrome and with learning disabilities. I think this might be new to some. There's definitely some new information from our own research, so that's a kind of an exciting part to share today. Then I'll discuss some literature review regarding exercise interventions and the effects of exercise interventions so far, and then we'll go over some of the barriers facilitators for adults with Down syndrome and with learning disabilities as well. Finally, the last part of this presentation will be dedicated to practical solutions. So that's from what we know to what we can do, and how to encourage physical activity for adults with Down syndrome and with learning disabilities. So without further ado, I'm going to get started with the review of the benefits of exercise and physical activity. As we all know, I think this is an audience that is well aware of these benefits. Active people have lower rates of a number of chronic diseases listed here, and older people actually have even more benefits because they also have the benefits of better motor control, cognitive functioning, a lower risk of falling, more self-esteem and independence throughout longer in their lives. So physical activity is super important for everybody, and these are the benefits that we all know about. For individuals with intellectual disabilities, it's a specific group, so it's a small percentage in any population. It's different from developmental disabilities, just to point out that it's not talking about people with autism or cerebral palsy per se. People with intellectual disabilities can have autism or cerebral palsy or other developmental disabilities because they do co-occur often. But for the group as intellectual disabilities, we're going to stick to the definition I mentioned earlier. Their life expectancy increased a lot from their 40s in 1960. And currently, the life expectancy is pretty similar to the general population right now. But due to a number of health issues in their later years at life, the additional lifetime healthcare costs for someone with an intellectual or developmental disability are over $1 million per person. So that's not the total healthcare cost, it's the additional cost just because they have that type of disability. So it's an important group, and with the aging effect, we need to know more about health in older adults with intellectual disabilities. So this was the reason why we started the big epidemiological study in Rotterdam on healthy aging in individuals with intellectual disability. This was my PhD project was part of this bigger research study, and I focused on physical activity and fitness, but the whole project included 1,050 older adults of 50 years and over, so a reasonably older population. What we found based on their pedometers was that they have lower physical activity levels than their peers in the general population. This wasn't necessarily new. We kind of suspected this would happen, but we didn't know how bad it actually was. So this is the graph of the people that were able to wear a pedometer. So this does not include the people in wheelchairs or the people that were walking too slow to get a valid measurement. So likely this is still an overestimation of the actual physical activity levels. But as you can see, only 16%, the two green parts, are complying with the recommended physical activity guidelines. And so only 16% is actually gaining the benefits of being physically active enough for their health. So that picture was shocking still, even though we were expecting that. And then looking at the fitness levels, at 50 years, they are comparable to 75-year-olds in the general population. So you see there's hardly any decline because they are pretty much all already at that low level. But it does mean that at 50, the physical fitness that would be involved in daily tasks and daily functioning is lower than you would need for a lot of those for staying independent. And that's not necessarily due to their intellectual disability. This is just their physical fitness that is influencing their independence. For individuals with Down syndrome, we saw even lower fitness levels. So fitness is not the only issue. We also know that obesity is a big problem in this population. There's a higher prevalence of obesity and cardiovascular disease. That's what we found in our study as well. But comparing the impact of obesity and fitness, it seems to be more important to stay fit for survival. So what you see here is a graph for 5-year survival, and the numbers that accompany that graph are here. And you see that the two top groups, the fit groups that are either fat or not fat, hardly have a higher risk. So the hazard ratios in the last column are your risks of not surviving the next 5 years. So the risk for the fit and not fat group is 1, so that's the baseline, that's the control condition, and anything over 1 is a higher risk of not surviving those 5 years. So the fit and fat group does have a slightly higher risk, but if you look at the unfit groups, both of them have a dramatically increase in their risk of not surviving those years. Being unfit is a more important risk factor for health and for mortality. We didn't just look at dying. That's not the only thing that matters. We looked at how well people were able to perform activities of daily living, because that's where independence is situated. And in those activities of daily living, it turned out to be more important to be able to walk than what your level of intellectual disability is. So more items were determined by mobility more than intellectual disability in this population. Then we also looked at some other health outcomes. We looked at how it was predictive for decline in daily functioning or for decline in falls or increase in falls. And both of those, like low fitness creates an unnecessary decline, both in independence and the quality of life. And physical activity and fitness do need to be improved for healthy aging. So that's kind of setting the stage. At this point, I want to acknowledge that it's almost even more important for individuals with Down syndrome. They have a higher chance for a number of additional comorbidities like cardiac abnormalities, muscle weakness, hypothyroidism, arthritis, cognitive decline earlier in life, obesity, cardiovascular disease, and diabetes. And with those issues in mind, they might be compounded by physical activity, or physical activity could partly prevent or delay these conditions. So there's even more reasons to promote physical activity in this population as well. So, do we know it's important? I don't think that was new to anybody, but I think these data for the aging population are worth sharing as they are new, and since that is a new population that we're increasingly dealing with. But now we're going to move on to some exercise physiology. So it's hard to improve physical activity, and there are some general barriers. We're going to go over those in a little bit more detail. But for individuals with learning disabilities, on top of those general barriers that everybody has, there's also some neurological limitations. So they have different intellectual functioning. They rely on others for some support or transportation or access. And then there's some motivational issues. So usually the focus based on those issues is on cognitive limitations and behavior, on changing behavior, on exercise or interventions that focus on how to regulate behavior or make it less complicated, and that's good, and we all need that. But there's also a physiology side to that, and I kind of want to give a little bit more information about that. So there's frequent complaints of fatigue, that activities being too hard or too difficult. And what we saw during our field testing for the HAID study was signs of exercise intolerance. So people were rapidly getting like sweating, rapid breathing. They were complaining of not being able to keep up with the pace. We did a 10-meter incremental shuttle walking test. So it was not a hard test, but people were really showing all the signs of being exhausted or going through really intense activities. But then at the same time, their heart rate wasn't going up as much as you would expect with those signs. So that gave us some clues about autonomic dysfunction potentially being part of this population. With that, we were interested in physiological differences between individuals with learning disabilities and the general population. So just to go over what the normal response to exercise is. When you start exercising, your heart rate goes up, your blood pressure goes up, your breathing gets faster and deeper, your liver releases glucose, your blood flow is directed to your working muscles because you need oxygen and nutrients to those muscles, but also more waste is produced and then removed from those muscles. So blood flow is an important part of the exercise response. And this whole process is regulated by the autonomic nervous system. So it's all the way down in the bottom. There's two branches in the autonomic nervous system. One that is causing, the sympathetic nervous part is causing fight and flight responses, and the parasympathetic nervous system is causing your body to go into rest and digest mode. Both those parts always work in concert, so they always work in a balance, and that balance just shifts depending on the type of demands that your environment poses on you. They regulate a lot of different organs, muscles, responses. So the fight and flight on this side, the rest and digest for the parasympathetic part on the other side. You can see how many different influences they exert across the whole body. There's it's also a very continuous monitoring of exercise. So if you would go for a sprint, there's and then go through different activities in that sprint, for example, like a jump, or there's all these different feed-forward reflex mechanisms, feedback mechanisms that all work in concert to regulate every single moment of responding to exercise. And not just exercise, pretty much everything in our environment, but this is going to be applicable to exercise. With this complex regulation, we in the max test, all those systems are activated. And in the max test, the question, how much can you do with how much effort? So maximal exercise test is really pushing someone to their maximal exhaustion. And that is very possible in individuals with learning disabilities and Down syndrome. In my experience, I've done over hundreds of those tests with this population. They really actually like it. They do need a little bit more time to familiarize themselves with the treadmill, with the equipment, with the procedure, but with taking the time to go through those things and to, in a playful way, to make them comfortable with the equipment, they are very much capable of doing a maximal exercise test. It just takes a little bit more time, and they really enjoy it. Out of the protocols that I've done, the research protocols that include a max test, almost with no exception, at the end of a protocol, I ask what they like most, and they almost always like this test the most because they like being challenged, they like being cheered on, they like to perform and to be able to accomplish a real good result. And I think they get a lot of satisfaction from that, just from that experience, because they don't get that much of those types of experiences. So the outcome measures that we are looking at for a max test are the peak oxygen uptake, which is the amount of oxygen you're able to use for exercise. This is the trainable part. So if you start getting better, if you train more and exercise more, you'll be able to put in more work with the same amount of oxygen, or be able to use more oxygen total by your muscles. The peak heart rate, we look at that as well. It's not a trainable feature. People do get a little bit more comfortable with intense exercise, so it might go up a little bit if you do 2 tests in a row or within a certain time. But by definition, it is something that is not trainable. It is depending on genetics and age. Age is an important factor. It comes down with age a little bit, but it's one of the measures that we look at to determine if a test is a valid max test. Then we also look at the respiratory exchange ratio, which is the ratio between the carbon dioxide and the oxygen. And this is really a measure for effort. So everything over 1 is considered a maximal effort in Down syndrome. So for Down syndrome, what we know, they have lower fitness. So this is a study in 2008 in a really large population of compiled data set of max tests in Down syndrome. And as you can see, that bottom line is their VO2. So it is really considerably lower. They also have more obesity and lower physical activity. So looking at that information that we know about the autonomic nervous system, that makes you wonder what is going on for Down syndrome. And that's not a question that we ask for the first time right now. That question has been asked earlier on, and there's been some research supporting what is going on. They have that lower cardiorespiratory capacity, but what they saw in research as well is that their maximal heart rate during exercise is about 25 to 30 beats per minute lower. And that is quite a lot. So if you use your sort of rule of thumb for 220 minus your age to calculate your maximal heart rate, 25 to 30 beats per minute is quite a considerable amount lower in that range. It is not explained by less motivation or not understanding the test. In those studies, they controlled for that amount of effort with the RERs and with that familiarization. Sometimes it's been tested with another test back to back, or with a number of tests, and those rationales support that it's really a physiological difference. So they came up with a different formula to calculate a peak heart rate for individuals with Down syndrome. And I just want to make sure that I do come back to this formula at the end, but it results in slightly lower peak heart rates based on this formula, what you would expect. And that's important because if you do heart rate based exercise training, you need to know that you have a different reference that you're working with than the regular high heart rates that they will never be able to achieve. So it has a lot of consequences for gauging the intensity of every activity. So for example, if you see a heart rate of 120 in someone with Down syndrome, for us that would mean we would maybe reach 120 for a reasonably nicely paced walk. But for someone with Down syndrome who maybe would only be able to go up to 160, that is actually a very intense activity. So it matters for all sorts of activities. So how does that happen? So from different types of studies, and I won't go into too much detail about those different studies, but they seem to have less sympathetic activity and less adrenaline, and a blunted withdrawal of parasympathetic activity. So withdrawal of parasympathetic activity also is also described as vagal withdrawal, but it basically means that system, the balance between those two systems that should go up towards sympathetic activity and should go down, is not doing that same shift as much as you would expect in the general population. But we're still working on improving our understanding of their exercise physiology and autonomic function. There's a working model that is published in a paper by Fernald et al. In 2013 that sort of describes how impactful this autonomic dysfunction can be in Down syndrome. So the dysfunction results in lower parasympathetic control. There's the two papers, I cited the two papers that you can find more information about that. They have less sympathetic control, but there's also less baroreceptor sensitivity. And I'm not going to go into that too much, but it's how heart rate and blood pressure are controlled in concert with each other to maintain good blood pressure. So vagal withdrawal in exercise is an issue. So with less parasympathetic control, there is with exercise less vagal withdrawal. So you would expect the parasympathetic activity to go down, but since it is not, it still is too active in those exercise intensities, which also means that heart rate doesn't go up as much. So the change in heart rate is lower in Down syndrome with exercise than it is in the general population. And this phenomenon is called chronotropic incompetence. From the sympathetic side, it also means that there's less catecholamines released during intense activity, so less adrenaline and noradrenaline that usually aid in increasing your heart rate, but those levels hardly increase in Down syndrome. So there's definitely a physiological difference there. The sympathetic side also provides peripheral control. So what I mentioned about blood flow regulation, that regulation is impacted by the sympathetic activity, by sympathetic nervous system. So with the question or with the information that we know, about heart rate and blood pressure, the systemic part, we actually don't know anything about how it would impact blood flow regulation. There's ways of looking at that with specific methods, and what we use is a lower body negative pressure chamber. And this lower body negative pressure chamber is kind of a fun machine. It was originally designed for astronauts because it can sort of simulate gravity. So people are laying down, they're actually fairly comfortable, and they're laying down in that box that you can see in this picture here. And in that box, we can manipulate the pressure. So we can create a little bit of negative pressure, which then draws the blood to the legs and away from the body. But then to maintain blood pressure, your body has to respond with a sympathetic response to maintain it. You can actually measure that in the arteries in the arm, because that's where some of the blood gets drawn away from. So this all sounds very experimental. It's actually not very comfortable. We use only minus 20 millimeter mercury degrees difference in pressure. And if you realize that just standing up will create an equivalent of minus 40 millimeter mercury, this is a very mild stimulus. It's only half of what you deal with on a regular basis throughout the day, but it's enough to see those differences happening in the body. So when we did the study with individuals with Down syndrome, we indeed found that young males with Down syndrome have reduced peripheral regulation of blood flow. So the responses that we saw in the arm were not as strong as they were in controls. So indicating a blunted sympathetic control. And this is the first study that is actually looking not just at the systemic control of heart rate and blood pressure, but also on peripheral blood flow. We're currently looking at the effects of exercise for this part, and the effects of exercise are going to be on peripheral blood flow and autonomic function. But that's currently the study that we're performing right now. What about individuals with learning disabilities? This was on Down syndrome. Down syndrome has, as you can see, those references. Down syndrome had a long history of research, and for individuals with learning disabilities, there was hardly any that don't have Down syndrome. So we started doing a similar study with that's the project I was doing as a postdoc in Chicago, to study autonomic function in individuals with learning disabilities as well. And what we found is that they do have a lower maximal heart rate. It's not as pronounced as it is in Down syndrome, but it's still about 10 beats lower on average than it is for their peers in the general population. They also have a lower VO2 max that could be related to just the maximal heart rate. But in the cardiopulmonary profile that we looked at as a whole during max test, we saw not just autonomic, but also ventilatory limitations and a possible peripheral muscle hypoperfusion. So the hypoperfusion is what we were just talking about, the blood flow regulation. So that warrants further research in individuals with learning disabilities as well. The issue with learning disabilities, as we all know, it's a very heterogeneous population, so it's harder to pinpoint the cause of those effects. But knowing that a lot of these functions are regulated in the brain, and that there is some commonalities in brain connectivity issues in individuals with learning disabilities, that could potentially be explaining why we see it in a large portion of this population. In some not published studies, we did see higher arousal during resting. So actually the opposite of what we saw in Down syndrome. So people with learning disabilities have that sympathetic system activated more and less of that parasympathetic activity just in all the resting values. So they have a higher heart rate and a somewhat higher blood pressure. But then in response to strength exercise, their blood pressure response doesn't seem to be as adequate as it is in the general population. So there seems to be more issues than we realize, even with just performing exercise or performing different tasks. And those could be related to troubles with exercising, but could also be related to a higher risk for cardiovascular disease. So that's definitely worth further looking into. I don't think I mentioned at the beginning, all the references that I'm mentioning, if people can't have or don't have access to those references, or just want a PDF for some of those parts, please feel free to just email me and I can provide you with more information. So the third part, this is going to move into a little bit more practical. So we're kind of done with the very basic science part of this presentation, and we're going to look at more towards the exercise interventions, but mostly what is helping and supporting physical activity and exercise in these populations. So for both the population I'm talking about, I'm going to cite 2 literature reviews that provide a lot of detailed information. I could talk an hour about these literature reviews, but I will really keep this part short because the reviews in itself give you all the information if you're interested in these parts. So the first review is from Lee et al. In 2013, and the conclusion of that review was that there's moderate to high effects on improving muscular strength, balance, and cardiovascular endurance of exercise interventions in individuals with Down syndrome specifically. And then a different review focused more on other domains as outcomes for activity domains and participation domains. And they also found a number of positive effects of exercise interventions on gross motor skills, stair climbing, bike riding, work task performance abilities, jumping and rhythm and dance. And even on the participation domain, including emotional barriers to exercise and life satisfaction scales. So I think in addition to the general benefits that we know of physical activity and exercise, for specific populations like Down syndrome and for learning disabilities, there's these additional benefits that they experience on top of that. For learning disabilities, there's 2 different reviews that provide a lot of information about the type of interventions and how you would set up an intervention like that. But those interventions also positively affected balance, muscle strength, and quality of life. And the second review of Heller et al. Included improved fitness, weight reduction, fewer maladaptive behaviors, improved adaptive behaviors, better attitudes toward exercise, and improved life satisfaction. And I wanted to include those parts too, because I think behavior is a really important part of our support for this group of people and for their families and their networks. So I think having results available or evidence available that physical activity and exercise actually improve some of the behaviors that they are encountering on a daily basis, I think would only support motivation to participate in those interventions and programs. So promoting physical activity, we know their physical activity levels are much lower, their fitness is much lower, so we know it's really important by now. But how do we do that? So before moving on to the barriers and facilitators, I wanted to take a quick moment to do some sharing is caring. So we are really curious this time in this specifically in the time now during the pandemic where we are more restricted in the types of activities that we can do. Please share what you have been doing, so from your own personal experiences, to encourage people with learning disabilities to be more physically active. You can use the Q&A section for that. And those ideas, please just add anything that you can think of, because it might give someone else inspiration to start trying something like that. And I think having this group of people together is a unique opportunity to share those ideas and thoughts and experiences with each other for a second. So please start doing that right now, and then we can all look at those ideas while we go. I will continue after the facilities and barriers with some ideas that we have here as well.
Please do ask your questions so that we can talk them through at the end. That would be great.
Yes. Yeah, questions on the entire presentation. Yes. So the facilitators and barriers that I'm going to go over are from a really nice study, an in-depth interview study done by Nahi and all in 2010. It focuses on Down syndrome, but I think it translates really well to issues that we run into for individuals with learning disabilities in general. So I think it's worthwhile going over those in a little bit more detail to realize what the setting is that we're actually trying to change. So just in brief, and I'll go over those in more detail in the following slides, but the facilitators are support from others, physical activity being fun or had an interesting purpose, and routine and familiarity. And the barriers could be lack of support, not wanting to engage in physical activity, and medical and physiological factors. So they performed in-depth interviews with support persons or support people or staff, with parents, and with individuals with Down syndrome themselves. And they really did a nice job in compiling all that information into a framework. So for the facilitators, they had 3 big themes, but then the themes were divided into others, like smaller themes. I'm just going to go over those in a little bit more detail to really zone in on the variety of different issues that we're working with. Support from others can be a really facilitating part. The decision to be physically active in itself almost always requires some support or some initiative by someone else. And then initiating physical activity, there's actually a lot that goes into that. So you need to organize that, you need to get your gear ready, you need to find a moment to do it, you need to find a way to do it. And so that whole part of initiating physical activity is something really hard to do by yourself if you're someone with a learning disability. So you need support from others to do that part. But then you also need some support to maintain interest. So there's some creativity involved, enthusiasm, interest, and motivation. So this is actually requiring a lot from the person supporting someone with the learning disability, because now when things are not quite like in the interest, it's easy to go for that after dinner walk. That's a really easy activity, but if someone is really not liking that or is bored by that, then it requires a little bit more creativity to find activities that are within the interests or passions of the person that you're supporting. But it's worthwhile because just look at yourself. If you're made to do or being included in something that you're really not liking that much, you're not going to be too excited to keep doing that. You just go through the motions. But if you find something that you really like, then you hardly need any motivation to participate and continue that activity. Another really important part that can help is in the whole support area is joining, doing things together. So one of the staff mentioned in this interview that when we have activities, the staff always participate. It's a factor that works. If I stand next to them on a treadmill, they don't respond. But if I'm on the treadmill with them, come on, I'm doing it too, we're all doing it. That works. So that's kind of the mindset that would really make a difference. It's not always possible. I realize that as well. But if you have that possibility, or if you can find ways to do something similar that makes it feel like you're joining the effort, I think that would be a great way to do that. To make an activity fun or purposeful is one of the other facilitating parts. So it's really important to make a fun environment. You can use music or add sensory elements like smell or taste or touch. Novelty is something that works. That also requires a lot of creativity to always come up with novel things, but knowing that novelty works, it is a way to sort of re-engage people that you're kind of losing their interest, or it's also good to realize that novelty is a temporary thing. So the fact that novelty is a facilitator also includes that it's not going to always keep working. So it's sort of supporting and confirming those experiences as well, but novelty does work. Group activities, so adding a social component, I think is always working. They had a number of participants that were explicitly looking for participating in group activities and doing those activities more for being part of the group than actually for doing the activities. Adding a social component anyway, you can think of buddies or meeting with people, or when you're meeting with people doing something active, so sort of reversing the activity part. Those are all ways to add that social component. Incorporating passions and interests, and that may sometimes be hard to figure out. Sometimes it's not easy to have that conversation because people have trouble verbalizing those passions of interest, or they don't have that many experiences to draw from. So at that point, if that's a thing, then it really, you have a lot of options to try out new things that they don't have experiences with, just to see if that would be a new passion or a new interest. So this is where the novelty comes in as well. But I think starting to take that passion and interest as a starting point, like we do for ourselves, I think is a really important part to keep people motivated. Another way of doing is making it purposeful. So going somewhere to do something, like going to the mailbox to get the mail dropped off, going to the coffee shop to get a coffee, like all those, if you can make it purposeful, it is not so much about the activity as it is about the purpose. And sometimes that is the way in to get people to be active. Incentives can sometimes work. Competition works for some people, not for all, but for some. And then rewards generally work really well, but have to be well chosen to be either lasting or not mitigating all the effects that you're trying to do with physical activity. So if you motivate all physical activity with bad food habits, at that point you start almost going counterclockwise or counteracting yourself. But that makes me think of the slide I just presented, that fitness is more important than fatness. So physical activity trumps everything. Examples of fun or purposeful activities from the paper are to pump up the music, and for them it was just reinforcement. They were strutting and enjoying it, so that's a staff experience, I think one that we all recognize. For an adult with Down syndrome said, well, just to be a little bit funny, make them laugh, so really to get a social component in there. And this is another adult with Down syndrome. She says, I go over there to bowl or to bowling and invite some friends over, and I think that makes it much easier for me. So adding that social component to keep things going and to keep that activity going is a strong facilitator. Part of daily routine is something that helps for a big part of our population, not for everybody, but for a big part of our population, this could really aid in just getting the daily physical activity in. So one of the parents said his life is dominated by ritual and procedures and predictable behaviors. Like every Saturday he knows that he goes bowling, and that's what motivates him rather than the desire to go and bowl. It's all part of his weekly routine. Routine is a big thing. So if that is the way your person that you're supporting is working well and really likes to organize the week, then that's really a nice way to include physical activities and just make that part of the routine. Then on to some barriers. I think those, we need to talk about those because we run into those, and those are sometimes demotivating and sometimes hard to overcome. But just sharing them, in my experience, is already like confirming and taking away some of that demotivation that we experienced ourselves working with this population. So lack of support can be expressed in many different ways. We talked about support being a facilitator and lack of support being a barrier is the logical opposite. But there's dependency in transportation, the need for someone to organize going, the need to supervise some of those physical activities. So really being like one-on-one or one-on-a-group supervision. There's financial support for transportation, for activities, for programs to participate in, and then there could be lack of community support. So a parent said she's very willing to have a go at any activity, which is great, really great. I'm probably her biggest barrier to doing more. The truth be known, by the time I get home from work, it's like, forget it. So parents are dealing with that on a daily basis, and they want to. It's not like they don't experience the necessity of doing these activities, but this is just what life is as well. So I think from our professional perspective, it's important to take that into account and to keep taking that into account when we get very excited about activities. We need to realize that this is part of what they are dealing with. Financial support can be a big part. If you are if only one person is the provider in the family, and that person they're already struggling to make ends meet and to provide the regular programs, it might be a barrier. And then there were parents that were not inclined to join like a bowling night because they felt like being there and being confronted with the situation that other other visitors of that bowling center were looking at this group and were like not really accepting of this group was too confrontational. So the lack of the community support to really venture out into the community was a reason to not really engage in those activities as well. So that's something we need to be aware of. And then we have the person with learning disabilities or Down syndrome just not wanting to do it. I think we've all run into those participants with just the lack of motivation, poor concentration or attention span, and sometimes a general dislike of any activities that require any effort. And sometimes they get easily bored. And then parents explain that or cite that as, I say, one of the main barriers is low motivation. Given a choice, he would sit in front of the telly all day. Or an adult with Down syndrome themselves is that, well, sometimes it gets too much for yourself. It's certain things like in your head, like I have to be. Remember doing that. Yeah. So sometimes it can be very complicated, some activities or situations, and that can result in not being motivated to engage in that situation. And I think as professionals, we're very well aware of always adjusting and adapting activities to the person in front of us, but not everybody in their environment might have that same training and might have that same opportunities to do that. So I think it's something important to point out. And last but not least, there are some medical and physiological issues that people struggle with or are scared of. So staff could be unsure if it's safe to do activities, and they probably would benefit from professional advice on type of physical activity programs. And I think this is where PTs come in. So PTs have the expertise to recommend activities that are safe and secure, but also add to the physical activity amount on a day in a safe way. And I think PTs are great advisors and could have a really great, nice role to both professional caregivers and to families to take away some of these concerns. So one of the staff members said that people that were really overweight, we needed them to go to the doctors for us to get the okay, because we really didn't know if we push this person, they really might have a heart attack, and we're not trained to understand that. So that really doesn't happen all that much. But people are uncertain about that, and I think as PTs we can mitigate a lot of those concerns if we know that those are in the way of activities. Another citation that I didn't include on the slide, but was that a lot of people can have issues like gout and find ways to deal with that, or to circumvent, or to how to manage that in a larger group might be hard to get people involved, or people in a wheelchair. How do you include them in activities with people that are not in a wheelchair? So there's different issues, physiological issues that could get in the way here. But I think PTs are the best group to be included on these concerns and to really help support that. Then people with learning disabilities or Down syndrome themselves can have uncomfortable or unpleasant bodily feelings. I think this goes back to what we saw with the field testing that we did in the older adults. A lot of the bodily feelings are unfamiliar. Some of them are not familiar with an increase in heart rate, or an increase in how warm you are when you start being active, or an increase in like sweating. A lot of people that, especially the older populations, may have not been too much involved in general PE and have not been too much involved in activities when they were kids. So they may not have a lot of the experiences that we just assume everybody has on being active. So when you get those signs and you don't understand where those signs are coming from, it's really not that comfortable to be hot and feel your heart rate and feel your breathing going up. So I think for where that is the case, we can really help people get more comfortable slowly with those feelings, but we can't assume that this entire population is familiar with this. And I think that's a big difference with other populations. Because they are so unfamiliar with it, they really do get very easily fatigued. So it's way in like a way lower stage and intensity than what we would think. So sometimes we tend to hold them to our own standards and say, well, that's not that hard, or that's not that far, we can do that. But it actually, for them, it actually is very hard and it is very far. So I think just trying to include that perspective in your approach is already, and being aware of that potential difference is already going to be helpful. So they complain, I feel tired, I feel hot. I stop doing exercise if I get aches or pains in my body. So with like strength exercise, if you get some sore muscles afterwards, we know that's normal. But if you don't know that, you don't know how to interpret that information. So I think that's important to help people with Down syndrome and learning disabilities be more familiar with and sort of educate them about what exercise does to the body. So I think discussing those barriers and facilitators already sets the stage for the practical idea and the resources. So I hope, I can't see the Q&A when I'm presenting like this, so I hope there was a lot of sharing of ideas, especially during the pandemic right now. Ingrid, is there anything you wanted to share right now?
Hi. I also can't see the question stream, but I'm being fed things as we go. And we've got lots of ideas coming in. Brenda has been doing obstacle courses. Kate's been mixing up rugby courses with mixed abilities. Lots of online sessions and supervising exercise sessions using online ideas. There's a sit to get fit classes that Kim put in. And using recordings as videos for further use to encourage people. And they've been finding that doing recordings has helped motivate people, which I thought was a great idea, one that I hadn't thought of, especially in lockdown. There's a lot of ideas for the pandemic times where rather than getting out there in big groups, these things have been done. I know in Wiltshire they're doing some online virtual kind of Olympic games and challenges through things. Piers has organised a Route 66 for residents in a home where they've been using adaptive bikes in a virtual route, which I thought was great. It's led by one of the residents, very motivating and giving a great purpose instead of just getting on the bike for 20 minutes. And I've seen that in some of the videos online where they've had several of these sort of static bikes in a room together, and people competing or adding to a total, or with a screen in front of them showing them some interesting places to go. I thought they were great. There's someone else who's been setting up a walking group, incorporating circuit training, rebound groups, lots of fun fitness groups, some of which have then come out of health and gone into social care setups. Lots of use in the park and even churchyards and things, looking for these places to exercise outdoors that are away from big groups of people during the pandemic. So there's some of the things that I've seen. And I've been trying to keep up looking at some of the questions that I could see in the background as well as watching you. And I thought that also somebody was talking about using some mascots. That was somebody from Holland, or the Netherlands, who was saying about using mascots and how popular that was. I don't know if you know about that project. You're nodding.
I think so.
Yeah.
Might not be the same project. I know.
No, it might not. And was using these mascots regularly over years and years to encourage movement in the group. And I can see that once you get into a routine where it's fun and interactive, that's great. It is such a pleasure to listen to you talk about this. We don't get to hear this kind of expertise very often, and it's wonderful to see it as a presentation like this. So I'm just really glad that you're here and able to answer questions. I've got a couple of questions written down, and hopefully I'll be fed some more as we go.
Ingrid,
yeah,
would you like me to go through just briefly through the practicals, ideas and resources?
Oh, yes. Do finish the last slides, and I'm getting
it's just
some of the questions fed to me. That's great. Thank you.
And then we'll do the questions. I think this is really the practical part. I think a lot of the good suggestions that people have shared are very much in line with some of those practical ideas and resources, but I wanted to share just so people have more resources to go to for inspiration.
Brilliant, thank you.
So what is the same with all those differences and barriers and facilitators? There's enjoyment, successful experiences, connecting with others, to be proud of your performance, to be cheered for. It feels good. So I think there's a lot of similarities for physical activity as well that we want to really keep in mind. So in line with the facilities and barriers, we can capitalize on facilitators by soliciting support, educate support people so they can provide that support, or find a team or an exercise partner. Different suggestions for that. To make it fun and purposeful, explore the interests, walk to the mail office, add those fun parts, and think of active games to play as a family or a group. Make it part of the routine. You can hide exercise in daily tasks. You can set a time or place for exercise and keep exercises familiar to get like really that complexity down. And then to create positive and successful experiences with activity and exercise is important. So to solve some of those barriers, you can improve access by keeping it simple, walking, free weights, free online workouts. Some of those have been mentioned during the pandemic as well. That's great. You can maybe partner as an organization with a gym or with a physical trainer or students. I think there's a lot of opportunity to work with students that want to engage in community participation as well. And then find ways to facilitate or find ways to enable adults with learning disabilities or Down syndrome to improve their own independence, to then start engaging in physical activities. Finding a partner, minimizing physical complaints. I think one of the main key things here is to take small steps. So don't go too fast, too much, because you only elicit fatigue, and that's going to really be in the way of doing it again. Remember that they experience intensity possibly different from what you may feel. It's no reason to not be active, but it's a reason to even break it down further in small steps. What I've used a lot as inspiration for people to slowly get into physical activity is physical activities designed for seniors in assisted living facilities. They start with a lot of chair-based activities because of safety concerns with older adults, and I think that's somewhat true for our population as well. But by doing it in a chair, you're also reducing the intensity a lot, but you can still engage in activities and some of those activities you can easily transfer those activities to standing or to walking activities as well, to get that intensity up slowly. So that's been another great resource. There's the American College of Sports Medicine guidelines that help with like how do you do it and what's the intensity that we're kind of working towards. I'll briefly reference those after this. But then overcome the cognitive barriers about like the people have been building up based on their previous sometimes negative experiences with activity. They've been building up like I'm not that person that is doing physical activity. There's a lot of cognitive barriers based on their previous experience. So sometimes just making it fun and doing something different is going to overcome those. So the guidelines say check with the doctor if there are any contraindication if you're unsure. Some activities may not be the smartest for Down syndrome specifically, so they have a lot of ear infections, so swimming might not be the best idea. They have atlantoaxial instability. Yoga might not be all that great if you don't have someone like a teacher that is taking that into account. A good teacher could take it into account and could make that safe, but that's not always available. Start slow, include strength exercise, especially in Down syndrome with the hypermobility that they have to support that, and check the intensity. You can do that with the heart rate monitor and then with the specific formulas. Simple, step-by-step, provide examples. Visual examples generally work really well. That's why the online courses actually are not that bad of an idea in this pandemic, because it's all visual learning. Take the time to practice and to repeat the practice, provide positive feedback, and make sure you be able to individualize intensity even when you're doing a group activity. That sometimes gets overlooked because we're kind of happy when the whole group is moving, but kind of try to find ways to make people give people options to go into different intensities. And then these are ACSM exercise guidelines that people can just look at, look at. I'm not going to go over those. So keep moving. Adapt to specific physiology, make it fun or purposeful or part of routine, involve others, check with your doctor when unsure, use available facilities, professionals, and expertise, and focus on the positive. And these are some I think, inspiring examples and resources, the Stay Active, Stay Well program that you're working with. I really like the activity that is part of that program. So do ask Ingrid for information on that, but other options are provided here as well. I'll keep this slide going, I think. Yeah, I want to thank the people in Erasmus and the people at UIC that I've been working with, been fortunate enough to do the research with, and I'm open to questions. I'll keep the slide going with the resources. That is it.
Brilliant. Thank you so much. I think I'm going to give you a round of applause from here. That's great. Thank you. We've got a few questions coming through, but I'm going to take the liberty of asking my first one, which I just think everyone gets surprises in their career. And you've been doing all of this research, and I wondered if you could tell us what aspects of your findings or what you've been doing has surprised you when you've seen it.
First of all, I think that's a great question, because I think surprises are the way how we change things and how we change our own career and realize that something needs to go differently. And I think especially for our population, there's so little research and so little known. We just have to go on what we know from other populations most of the time. So when we get surprised, usually that is a sign that something is actually different. And to me, that happened, first of all, when I was doing the field testing, when I was seeing them really being exhausted, but then I was downloading the data from my heart rate monitor. I was like, they didn't really perform well at all. And I checked that heart rate monitor, see if that was working correctly, but it was. And then I saw that more and more, and I realized there's actually a difference going on physiologically that is not in line with the signs that you are seeing in the person in terms of the intensity that they're experiencing. And I think the second part was experiencing how much fun people have with the Maximal exercise test, because before I started doing that, I really thought that was really torture and like really hard to make people like go that long, like really get them to that effort level. But it's not. They really like it. They enjoy the exercise. They enjoy being able to really set like a new performance that they've never had before. And I think that's very similar to other people that do a max test for the first time. So it's kind of nice to challenge yourself every once in a while. And if you have the right support and the right familiarization and comfort level, I think it's a very possible part for everybody. And that was one of my big surprises doing that.
I hope that also will encourage other people to think that they could do research with people with learning disabilities, because there's a feeling that that's too hard and it's an under-researched area. And so knowing that some of these protocols are possible, it should give encouragement to people, as well as give encouragement to us in kind of healthcare or community settings to ask people to work a little harder. It's great. So.
Yes. And I think we're not doing anybody a service by not at least asking that. So sometimes, like, there's definitely people that don't want to do that, and that's okay too. Not everybody has to be on that treadmill doing a max test, but there's definitely a larger population than we usually think that is perfectly fine doing that with some help.
Yeah. Thessa, as we've got to this part of the talk, if you closed your PowerPoint, we become slightly bigger, and that would be great. I'm not sure I want to see myself bigger, but we have had a request to come through so that we look slightly bigger. That's great. Thank you. One of the things that you talked about in your presentation, which just really struck a chord with me, was that idea that some of the people we'll be working with have never had the reassurance that these changes in response to being active, like breathing faster, getting a bit warm, having a heart rate that you can feel, is normal and actually great. It's what we want to see. So that's something that from your talk really does change my practice, and I think we're going to have to be injecting a bit more novelty into things. We can no longer be satisfied with giving an exercise program and thinking that's it forever from us. So yeah, I think there's going to be a bit more novelty we'll have to add in. You're making us work harder as well as our clients. So We do have some lovely questions coming through, so I'm just going to go through them in the order that I've been passed them, which means I have to read them off my phone so that I can see here. So one of these, I don't know who it's from, this one, but have you investigated what kind of physical activity is most effective from a physiological point of view?
No, I have not investigated that personally. What the literature sort of agrees on is that a combined exercise program is most effective to address a lot of different things. So combining cardiovascular endurance with strength exercises is generally the most effective to get a wide range of health outcomes. I think specifically for cardiovascular risk, we've long leaned on more the cardiovascular aerobic, like long endurance activities. I think strength exercise is one of the programs that we investigated in Rotterdam to actually reduce cardiovascular risk is also a very viable option and potentially easier to adhere to than those long bouts of treadmill walking or biking that are just boring. So I think a combination of things is generally a really smart way to go and the most effective way to go. But you can definitely make accents depending on your personal preference as well.
And we can use our body weight in the strength training.
Yes.
As the resistance. One of the websites that we've been finding very useful is the Royal Osteoporosis Society. They've had a strong, steady and straight campaign with lots of exercise videos online, and we've been sharing that during the pandemic as well as before. And so the strong component is all to do with strength training. The steady is balance training, and then the straight is posture. And they seem to be quite overlooked areas to combine with this cardiovascular fitness that you've been talking about. They're really relevant to our population, really. Mm-hmm. So that's one of the questions. Let me just open the next one. This one's from Nicola.
Well, in addition, if people are looking for ideas to do those weight-bearing exercises, we've published a paper on a resistance exercise set just last year that suggests some of those exercises and also adaptations that you can do with those exercises if people are experiencing some limitations. So,
and also we should mention in the UK there's an office of the Chief Medical Officer. Chief Medical Officer, I think it is, who's been publishing lots of PDFs about activity and how much activity we should be doing a day and a week, including several bouts of strength training and things. And we do have the intention, probably more when we get back into our more normal service, of starting to include some of those pictures of how much activity we ought to be doing into the back of our discharge letters to try and increase awareness of what the safe kind of recommended activity levels are for people, right, both in the general population as well as people with learning disabilities. So there's quite a lot of information out there, and they've got an accessible one for people with disabilities as well.
But I think the PTs have a really crucial role in sorting that information, because I think there is currently a lot of information out there for people that search for exercises online. But having a PT that can sort of sort and select some exercises that we know are going to work is really going to be critical to help people and parents and support caregivers to get to the exercise that actually work, because they don't know how to make that selection.
That leads to one of my questions, which I'm just going to interfere the flow of questions with and just ask you, which is, when we're doing our work in the communities, whether it's us as physios or in the health team, or whether it's people working as health practitioners or fitness trainers or people working in families, how can they monitor exertion and comfort during activity to try and get that sweet spot between doing enough and overexertion? So have you got any kind of ideas of how we can do that practically? We don't have a lab. No. And should we be using the Borg, an adapted Borg scale, which kind of goes from not very difficult to maximal exertion with smiley and faces, or what do you think?
I think taking the participants' experience as the center point in that, I think that's the first starting point. So not thinking of an activity as what it would do to us but really looking at the participant in that activity, how he or she is responding. So looking at bodily signs like sweating, a red face, panting, trouble talking while she's doing that activity, or he or she is doing that activity, are all great signs to keep that activity. So like moderate activity, you should be able to keep talking in a normal way. So that's a really great, easy test to do. And I think a Borg scale would work for some people. It doesn't work for everybody. Sometimes it's just too hard to relate your own experiences to that. So but
your eyes are your best tools, what you're kind of saying. Your
Yes.
eyes and kind of feeling and being empathetic to the signs that they're showing. Is that?
Yeah, and I think just sometimes people don't prioritize those signs over some of the other information that you have as a professional or from your own experiences. So I think
feel like it shouldn't be so hard, but you can see that it is, and maybe that's where we have to stop.
Yeah, and I think it depends on what kind of activity you're aiming at. If you want to do moderate intensity, you can use talking. If you want to go more intense, then it might be a good idea to use a heart rate monitor, or like there's a lot of ways to measure heart rate nowadays with phones and with like more easy measures maybe than a heart rate monitor. If you have a heart rate monitor, that's great. That's a really nice feature if you're doing an exercise training. But out in the community, I would go by the participants' experiences and bodily signs. And with the motivation being part of that experience that they're going to be verbalizing, I would try different things to see if that experience is related to a specific activity that they just don't like, or if it's more in general intensity feedback that you're getting.
Have you come across any very inclusive versions of the kind of fitness tracking devices that are around? I'm trying not to say any particular brands, but there are loads of fitness tracking ones, and I can come across very simple kilometers, but I'd love a really inclusive, simple fitness device that maybe didn't require very expensive background kit that would be available to be able to use. So if anyone's watching this and gets inspired to invent that would be brilliant. You haven't come across anything?
I haven't come across a specific device, but I do think because, well, I'm not sure if that's the same everywhere, but here phones are a very high commodity amongst people with learning disabilities as well. It's their window to the outdoor world for a number of different purposes. And phones do track activity pretty decent nowadays. It wasn't that good at first, but it's not that bad right now. So for number of steps or in activity total, I think you can get a decent estimate if they're bearing their phone with them.
Okay, so try phones if they're able to use it. I can't ask you all my questions. So we have a question from Nicola. How do you think paediatric services can prepare patients to be more active? So children with Down syndrome don't typically receive input after they're walking. And is that a disservice to them? Should we be doing more, really?
With the experience that I have with older adults, I would encourage to provide experiences in a wide range of activities for the children to get more familiar with different types of activities and what they may like, like in addition to walking. I think if that answers that question, if I understood that question.
So, they're giving that range of experiences, so there is more than just getting to a point of walking and saying that's it. There's a whole kind of health promotion.
Or is this question about the skills?
Yeah, so Nicola asked, do you think paediatric services can prepare these patients to be more active? So after they're walking, people with Down syndrome don't always get further input from their services. And maybe that's a disservice.
I think, re-listening to that makes me think of that part like a lot more from the skills perspective. So I think walking stairs, being able to jump, being able to throw a ball, those are really skills that you would almost run into every type of activity that you're going to be engaging in. And that goes beyond walking. And we've had people that are uncomfortable with those types of tasks because they just never learned. There's also a lot of gait issues that are not like, as soon as people just walk, I don't think that's as much the case right now, but previously walking was sort of the minimum. If they could just move from one point to another, where a good gait that would prevent issues with joints and with falls was really not the main concern. So improving a walk to the point that it's like an actual safe and healthy walk, I think is a lot more the focus right now. But yeah.
I think we're going to have to go for quick fire in order to get a few more questions in. So did you have any thoughts about sensory processing issues that might be a barrier to physical activity? Have you come across that in your research, such as proprioceptive or vestibular challenges for people? And that's from Alex.
Yeah, I think that's an excellent question. I am definitely not an expert on that, but I know it is definitely an issue. So I would definitely refer to expertise and literature on that topic to get more information. I'm not.
We've not come across it, so maybe it's an area for future research. Do you think that there's any fitness testing that should happen before, or by a doctor or a qualified professional, before people go to, say, an organised football session or a different kind of sports session? Is there anything that absolutely should be being done?
The ACSM guidelines provide really good guidelines for when people are high risk and what they should check or screen for in those populations. So I'd refer to the ACSM guidelines. There's a specific chapter on intellectual disability and Down syndrome in the ACSM guidelines. But the screening and the pre-exercise screening and whether you're a high-risk population is specified really, really nicely in there. So not necessarily. That's my short answer.
Nothing specific, but it was covered partly in your slides. And if there's any if there's any concerns, they can refer to a doctor or health professional. But otherwise, so long as people look comfortable and they're exercising, getting a little out of breath, but can keep talking, that's a moderate level activity, and that's great.
Just as for anybody else. So if there are specific risk factors that you're concerned about, go to a doctor, get expert advice. But for anybody else who is just like us, there is really no reason to, you have to take those physical or physiological limitations into account in how you build it up. And where you start, but there's no reason not to exercise.
There's so many downsides to avoiding the physical activity that those initial thoughts about safety are almost overcome, really, by the downside of not being active. Is that what you're saying? Fair enough. We have a question that's making me concentrate just to read it. So Ed from Mencap's asking, during your research, did you identify or test physical activity sessions that can be attributed to a certain level of effort, such as is a 25-minute brisk walk, is that like 75% of your effort levels? Do you see what I mean? So is it possible to kind of gauge specific activities? It sounds to me that that's probably very individual.
It is. There are some translations about the amount of physical activity in terms of how that relates to your physical activity guidelines. So if you the 10,000 steps, for example, I think equates to over an hour of brisk walking. So that's quite a bit. 10,000 is also not really the recommendation that is all that great. But I think if you keep the intensity in mind, like moderate intensity, and then you just monitor the time, I think you have at least a good reference to those guidelines. But I'm not sure if that's explicitly.
And he was also asking, in terms of his interest in planning and delivering physical activity sessions in a supported environment. Mencap, they provide a lot of support in the UK, and so I suppose there's an element of bringing lots of individuals who might be quite varied together to do activity. Maybe starting a session with, we all need to monitor how we're feeling. If you feel very tired, let us know, stop, talk about how you're feeling, and we'll let you know if it's time for, or it may be time for a rest if you want to, but otherwise you might just want to stop for a moment before you continue. Would they be the sort of things that you might be recommending saying?
Yeah, and starting slow and seeing where people are starting to respond differently, and then adjusting the intensity based on that for specific parts of that group. But I think that's where individualizing intensity in a group comes in, and it's hard. It's the bigger the group, the harder it is. And at some point, if you have really big groups, it might be more feasible to make groups based on intensity level that you are able to achieve with those groups. There might be a really high performance group that needs a lot, and it might be a really like a starting group that just needs a lot of different activities to just get started. So depending on the size of the group and how you're able to organize it, it can be really hard or really easy to adapt it. But in general, if you have activities that you can, like if the same activities can be done with different intensities, like from a chair or standing or with a jump, like those are three very different intensities, and if that all involves is all part of the same activity, then it's kind of easy to
People
adapt.
People can be finding their levels then, can't they?
Yes, yeah, and still participate.
As we begin to bring it to a close, I'm just going to ask anyone who's still online and watching if you can, at the end of it, when the last slide comes up, there's a Mentimeter page where you can put in your thoughts and feedbacks about the presentation, about the format, about what you've heard, and it'd be great to hear some feedback. One of the things that I really gained from listening to you during the talk is it completely reinforces that feeling that we have to become less reactive rather than starting at the point where somebody is falling over and deconditioned, starting way back before that, trying to avoid them getting to that situation. And that's not going to take just physios or just exercise professionals. It's going to take everybody kind of working together to increase activity to do that. And that kind of permission to say, let's try and be a bit more proactive and think about the health promotion. It's been great here. We've had some standards of practice that have come out from the Association of Chartered Physiotherapists working with people with learning disabilities. That's a long statement, ACPLD, and their standards of practice now incorporate that health promotion element. And I think if we can try and start saying, this is core to what we do to avoid some of these other issues, it would be great. Do you feel a bit similarly that should be a bit of a target?
Yes, and I think in addition, because there's other people involved in that field as well, but I think the specific expertise that PT bring to that game is that ability to accommodate some of those medical or physiological concerns into advice on how to be active and how to exercise.
And some of the individual disabilities, you know, kind of a way that somebody's arm doesn't work so well in a particular activity. So we all kind of take a part in that. I suspect that we should be drawing this to a close so that Will can put the final slide up. With the link to the Mentimeter, so that everyone who's still joining us and has been here, I believe that we got over 200 people at the Maximum from all over the world, from different places in the States, from Holland, from across Europe, from Ireland, from the UK. So I think I saw one number of 235. I don't know if it went up from there, but there you go. So it's been great, and we're going to try and put this online so that people can find it. And the different networks that we've invited to this, we don't have any register particularly of who's come. We'll just send out the link to where we managed to post it. But thank you for attending our first webinar. Thank you for giving our first webinar. It's been brilliant to hear you. So thank you. Thank you very much.
Thank you so much for having me. It was a great pleasure to do this. Thank you so much.
Thank you. I'm going to give you a round of applause. Thank you.
That's brilliant. Thanks very much, Ingrid, and thanks, Tessa. I'm going to hang up now, and I'll just do the closing remarks for everybody. Thanks very much. Bye. So that ends our web day, and I'll just put on that final slide for you. As Ingrid mentioned, there was over 250 people on the call today. And it was fantastic to see people from so many different disciplines and from around the world, as you said, from California and to Ireland and all across the UK. sharing ideas and insight. So as Ingrid mentioned, this is a new type of broadcast for us all to deliver, and we're hoping to develop them and make them more engaging and useful for the audience. So you'll see here that you can leave feedback and send that via the Menti website. So that's www.menti.com. And if you use the code 164911, that's 164911, that'll take you through to the information page for us to leave the feedback. So I'll leave that there for a minute or two so you can take that down. But thanks again to Ingrid from Wiltshire Health and Care and from Dr. Thessa Hilgenkamp from the university. Thanks very much. Bye-bye.